Hey everybody, it's Dr. Galvin with the coronavirus update tonight. Tonight I've got a special guest with me, my friend and colleague, another emergency physician, John Bream. A little bit about John. He trained at ECU. You went to medical school and residency there, both, right?
Yeah, undergraduate medical school residency, 11 years in Greenville, North Carolina.
And as a
very proud pirate here. So
ECU, sure. And as an aside, John may be the greatest living and most frustrated ECU fan out there. But that's
definitely been a lot of reasons to be frustrated lately. But we're talking about the coronavirus today.
That's right. So as usual, I'll start with the numbers. We crossed the 2 million total infected number worldwide. 2,073,000, 134,000 deaths, 509,000 recoveries, and worldwide 17 million people have been tested. In the U.S., we've got 641,000 cases. 28,000 deaths now. We've had 27,000 recoveries, I believe. No, I take it back, 18,000 recoveries. And we've only done 3 million tests, John. 17 million worldwide. We have the biggest outbreak. We've only done 3 million tests. And then in North Carolina, what are our numbers now? 5,200 cases, 127 deaths, and nobody recovers in North Carolina.
Right.
Done 67,000 tests locally. So, we've talked a lot about the testing part of it and our frustration, and we understand that testing is a huge part of solving this. And so we had chatted a little bit beforehand, and so we thought we would start everybody with, what is it going to take for us to get back to normal? 2 months ago, if we told you this was going to happen, nobody would believe us. And now, all of a sudden, we're wearing masks to the store. We're locked in our houses. And so what is it going to take us to get back to normal? And John, you want to start what?
I think, I would open with sort of, the statement from the WHO, a few weeks ago. It says it's simple: test, 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 and test. I mean, that was the quote. I mean, now you can, obviously the WHO has come under some fire, politically, and, we'll sort of stay out of some of the politics of this, whether or not that's deserved or whatnot. And, obviously I think everybody would agree that this sort of could have been handled better from the start. But, testing is really the main pillar, I think, of getting us back and going. Testing is, you and I both know it's really been hit or miss in North Carolina. It really depends on which hospital system you happen to be affiliated with, what your testing availability is. I think it's safe to say in generalities that, the Charlotte market, the Charlotte metropolitan area, is generally doing a pretty good job with testing, and you can see that reflected in the numbers of, generally the higher positives in the Charlotte metro comparatively to other parts of the state. But, a big part of, us getting back open is going to be the ability to test, hospitals, to their employees, to large employers. We're going to have to get to the point that if we want to reopen some of these, larger businesses, that you're going to have to be able to get your nose swabbed and get a point of care test done. That's obviously an accurate test to, get these large factories and businesses running, or else we're going to end up with a bunch of meat packing plants in South Dakota with major outbreaks, and then this is just going to spiral out of control.
Yeah, and then the other side, testing is two-part, right? It's testing for people that are positive for the virus, but also testing antibodies to see if you had it already. Because if you had it already, we think that there's a good probability, at least for a period of time, you're going to be immune. And if you've had it and you've got a positive antibody test, then you shouldn't have any restrictions probably to go back to work. So does that mean a card or like something on your phone like they're doing in Korea that says, hey, I'm good, I've had it already?
Yeah, I think there's, I guess that's part of, being an American, and I've seen a lot of people, posting about this, that, the line between individual freedoms and, being kind of in some ways kind of quote unquote followed, by the government, to say, hey, I'm immune to this. But, I think some of the worrisome things, even about if you look at antibody testing, the most recent things that have come out we're not sure how accurate it is. There are some evidently very accurate tests that are not widely available. There are some widely available tests that aren't very accurate. And so that's one thing that's got to be solved pretty quickly is, not just testing, but we've got to have good, accurate, reliable tests. And then the other thing we still don't really know about antibodies and immunity is nobody's really sure. We know you form antibodies to this. We know that being infected with the novel coronavirus confers some degree of immunity, but is it for 4 weeks, 4 months, 4 years? Nobody really knows. And so if you look at, I read actually there's a study out today out of Science Direct, and it was, quite frankly, a little unnerving that we just don't really know. And there are a lot of estimates that think that, it's just going to be like the flu, that you might get some immunity, but there's going to be some small mutation that renders you non-immune every year. And in that regard, then this is going to change how we have to, for us, not just how we practice medicine, but how we live forever. And that's going to be, a heavy lift for us. And this is going to be a huge societal change for everybody.
And, the other thing is that we know that testing, it's not 100% accurate, when we do the testing for the, and what are we still about 80% accurate? So 80% of the time, if you have the virus, it's going to come back positive. And 20%, if you have it, it's going to come back negative. So even a negative test doesn't really give us the whole story, because we've had, you and I both had experiences with people that were like, no, have it, and their test comes back negative. So
right.
What do that? And, now that antibody testing is starting to become available, at least we'll be able to, go back subsequently and look, but does that require doing 2 tests on those? And we don't have any protocols in place currently to do multiple tests on suspected people. But, all these things are up in the air. And again, you got to know the accuracy of the test that you're using. And, these rapid tests tend to be less accurate in a lot of ways. How you do the swab, I said to somebody that was doing one of the swabs yesterday, I said, did you pull a memory out? Because
right.
Right?
It's called a Bream biopsy.
Exactly. It's got to go way up there. And if you just swab on the outside, then it's likely you're not going to get it. There was a study that showed, they did a study with masks where they were looking at virus propagation, and only about 30% of people, when they're coughing, were propagating virus out a long distance. Mm-hmm. Masks stopped 100% of that. But it was interesting that only detected the virus 30% of the time in people that were positive. So, we also know that there's an indolent time where you're infected and you're infectious and you have no symptoms. And then I don't know if you saw the study out of China that looked at they did testing on a bunch of people that they suspected, and about 50% of them were positive and asymptomatic. And then subsequently, about 20% of that cohort never developed symptoms. So that's kind of interesting that we have people who are testing positive for the virus and potentially never developing symptoms. And
I was trying to find. I'm actually pulled out my phone. So a guy, I trained at, obviously talk about training at ECU, and I trained with, there's 2 pretty prominent bloggers in emergency medicine. You have Sal Rezai, who does, Rebel EM, and then Ryan Remdisivir, who does EM Lit of Note. And they both, interestingly, we all trained at ECU together. And then he posted an article on his page, www.emlitofnote.com. And so he posted this article. It's basically a prevalence study out of New York, actually out of labor and delivery. And basically he said, COVID is everywhere. And they screened, this is at New York Presbyterian and Columbia University Irving. They basically screened an obstetrical intake prior to delivery. 215 women delivered. And 29 patients who are not experiencing any symptoms of COVID-19 tested positive by PCR. So 15% of people at this convenient sample in New York. Obviously now the incidence in New York is way higher. So, but this is just a convenient sample that showed that the asymptomatic population rate, not in China, we're talking in the United States of America, was 15%. So there's a lot to digest there about asymptomatic people and what that means for transmission and flattening the curve and all those sorts of things.
So in terms of us moving from lockdown to some mediated form of that or complete back to normalcy, I think that you and I would both agree that back to normalcy is not in the cards for the next year or two.
And yes, I think that's very, very likely.
But that doesn't mean we're not going to be taking some steps. And so the way I think you can look at it is that there's one of two ways to do it. One is you lock down everybody, you test, you identify the people who are sick, you identify their contacts, and you kind of lock everything down. And then what happens is you have this sort of slow roll through the population. And we know that until 70% of us have it, there won't be herd immunity. And we either have to be immunized or have had the virus. And so that's sort of the long slog, right? You make restrictions like China did for 3-4 months. My daughter has a friend who was teaching English in China, has been in Shanghai the entire time. And she was locked in her apartment for 2.5 months and not able to leave. They just now have given them the ability to, as long as you have like a certain thing on your phone that shows you haven't been around anybody that's had it, you're able to go out of your house for a couple hours, 1 day a week to go run errands. So that's the level that they've been doing now for months. The other thing is if you are a little bit more hard-hearted and say, you know what, there's a certain acceptable death rate, then you open up those restrictions earlier and you let the virus reignite. And maybe you just say, you know what, the healthy people go back to work. You guys, a lot of you guys are going to get sick, but you're going to be fine. We know that the majority of the people that don't have risk are not going to get deadly ill. Some of them are, but if you have chronic medical problems, if you're elderly, we're going to keep you locked down. And then we're going to get a bigger spike, but we're going to hit that 70% number a lot sooner. So those are probably two sides of the coin, and there's moral and ethical discussions about each of those. But I think we talked about the World Health Organization had some guidelines, and there were some leaked things from the government where they're talking about doing things in 2-week blocks. And so why would we want to do something, restriction change in a block of 2 weeks time? Because that's the incubation time of the virus.
Right.
If we release something, and all of a sudden 2 weeks from now we get a big spike, we need to know, but we have to test.
Right.
The frustrating thing I think for us is the lack of testing.
Right. Yeah. And like I said, testing remains an issue. I wrote down a couple things that, as far as, responsibly, reopening, the hashtag reopen and see sort of what that would take. So we talked about, testing, antibody testing. You sort of talked about a little bit about the increased ability of health departments to do tracing, contact tracing and isolation. That obviously assumes we're going to continue to do, social distancing, even if we open up, some parks and things like that, which, honestly, I think it's you probably can't open up the playground where, kids are going to be riding the, merry-go-rounds and the horsies and all that stuff and spraying their saliva everywhere and coughing all over each other. But, you can open, hiking trails and bike trails and, things like that are more, adult oriented, are probably reasonable as long as we keep 6 feet apart. Ramping up the production of PPE. And that's going to be the big thing, not just, you and I know it's been hard to get personal protective equipment in the hospitals. We've seen the pleas from, hospital CEOs asking, hey, if there's any PPE in the community, like, please donate. But, it's not going to be easy for the general public to get. And so even if you want to, let's say just something as simple as go get a haircut, that's, 30-minute exposure to somebody who could be asymptomatic. So it's going to require both of you wearing masks. And, I think there's an interesting study that, I read on, Dr. Rezai's site, the Rebel EM, that, if you're just wearing a simple surgical mask, what they did was they held a culture auger a foot from your face. And they made you say, ah, and then they captured, your bacterial loads there. And so then they put a mask on you and had you phonate at time 0, time 30, time 1 hour, 90 minutes, 2 hours, and 2.5 hours. And at 2.5 hours from breathing, you build up so much moisture on the inside of your mask that actually the bacterial counts on the auger were the same with no mask and at 2.5 hours. So it's reasonable to say not only do you need to wear a mask, but you've also got to change that mask, with some frequency, or else you're going to build up so much moisture on these kind of thin 2-ply masks, or else, you're just going to end up really doing no good. And that's bacterial loads, and these viral loads are going to be much smaller particles, so the time frame is probably shorter for that. But the other things, if proper sanitation processes for if we do somewhat open restaurants and allow you eat 2 tables apart. We have to make sure that we're sanitizing everything appropriately. And then there's going to have to be some element of, I'm not sure how you do this, if it's going to be police or deputies or park rangers or, I don't know how you're going to enforce that. But you're going to have to also be able to enforce these measures. Like who's going to be going in the restaurants and making sure that, hey, this is going to be getting done? Are we going to, the health departments, I mean, they're already probably stretched now. I'm assuming they're still doing inspections for public safety and whatnot at restaurants. Are they going to enforce this and fines, and then the vaccine, and then, those are, and they're really ramping up the Defense Production Act. I think there's a lot of things that are going to have to be done. And, a lot of this is, reliant on the government, which is, and obviously there would be public-private partnerships. I'm not trying to make some endorsement of big government here, but to do all of this is going to take a lot of time. That's kind of what I'm getting at here, is that we're looking at, a vaccine is 12 to 18 months, but even just to get this other stuff done that seems very basic, we're still talking about, weeks to months to get, a good antibody test, to get mass testing done, to get the factories to ramp up the PPE, to develop algorithms, and for the state to develop algorithms for proper sanitation and protocols, who's going to enforce these things. All these things, this is still going to take a long time. And I know, one of my good friends, it's in my group chat, he told me, Jeremy Phillips, he's like, man, this is killing me. He's a chiropractor, and he's like, it's just killing my business. I'm a small business owner. And like, I hear you. I mean, man, full disclosure, my wife and I opened a store, and I think we opened up at the end of January. And so like, I hear you. We had to close 5 weeks in, and it stinks. I mean, there's no way around it, but it's just it's a very difficult song and dance. And so, what I told Jeremy is last night is like, look, man, I feel your pain, but if we look at this virus, I went back and sort of tracked some of these memes. And I think one of the ones that I remember catching my eye at the beginning of March, and everybody thought we were blowing this out of proportion, was this just the swine flu. There's no panic about the swine flu. And I'm like, well, the swine flu in America infected 60 million people. So it infected 100 times as many people as the novel coronavirus. It killed 12,000. So this virus has infected 100 times less people. So it's infected 1% as many people as the swine flu did, but it's killed almost 3 times as many, or 2.5 times, and certainly going up. So this is going to end up killing, at least 3 to 5 times as many people in America, despite having, not even like a 1/100th of the cases. So it's just comparing it to swine flu. You're like, wow, this is so much more. Even though it's not as prevalent, it's much more virulent.
Right. And I think that 60 million, was that just in the U.S. or was that worldwide?
That was in the U.S. and the worldwide is like 1-point-something billion.
So right now we're at 2 million worldwide, and 650-ish thousand in the U.S. And so those numbers you can see. And remember, we talked about 70% have to be exposed. So when you extrapolate those numbers, and I've had people, business people and other people that are on the same boat where, we're all kind of struggling as business owners. And, they're like, well, there's like a certain acceptable risk. Like, what's that number? 100,000? Is it a million? Is it 2 million? And, unfortunately, if we extrapolate to that 70% number based on the numbers of death now, that number is very, very large, ultimately. And, these numbers that they're talking about with Fauci, 60,000, that's not for the course of this illness. That's like by whatever date in the summertime. This is going to, likely spike up again in the fall, winter time. And again, we're going to be dealing with this for a period of time. And so these restrictions are important, but we do need to figure out some way to get back to business. And, we're not going to answer that question here tonight. But, for us, one of the things we've been seeing is like people coming in to the hospital a lot sicker than they should because everybody's afraid to go to the emergency department because of why? Because we told you guys not to come. But now what's happening is that, people are coming in a lot sicker. So let's talk a little bit about, we're not saying don't come to the emergency department for anything. We're saying don't come to the emergency department if there are other options. But if you're having chest pain or, you break your leg or something like that, then obviously you need to come. And luckily, we've taken precautions to protect people, right, John?
Right. Yeah. And so, I mean, obviously, a lot of people may not know kind of the rules of governance of emergency departments, but, if you come in the door, we are required to screen you, to do a medical screening exam. That's a federal government guideline, and that has not been suspended or changed in any way. If you come into the emergency department for any reason, we are going to see you and do everything we can to take the best care of you. But we have started seeing some articles out there. There's an article, I think, is out of Fox in Memphis this morning, talking about how an ER doctor was talking about how people just aren't coming in. They're coming in sicker, or they're just not coming in. If they're having a stroke or a heart attack or something, they're just not coming in because they're scared they're going to catch the coronavirus. So, I think, as I can speak in generalities here, that emergency departments throughout America have been preparing for this, since at least early March. And so, there are, and obviously ERs are not one size fit all. You've got some ERs that are 4 beds. You've got some ERs that are 120 beds, to see a couple thousand people to, 180,000 people a year. So it's not one size fits all, but to the extent that, your emergency department is able to do this, there's been guidance nationally that, you should be segregating the non-COVID coronavirus patients from the coronavirus patients. And, so if you're, come in and you're having, no fevers, chills, cough, you're coming with chest pain, that you're going to go to the part of the emergency department that is, not seeing the coronavirus patients. So your risk of, contracting coronavirus in the emergency department is, honestly, very, very, I would say it's zero, because it can't be zero, but it's infinitesimal. It is tiny, 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 tiny. And everybody's doing everything they can to prevent that from happening. So if you are sick, if you're short of breath, if you're having chest pain, if you are not feeling well, if you have, something that you feel is an emergent condition, by all means, come to the emergency department. We're still there not to help the coronavirus patients. We're still here to help everybody. And, we have an oath to do so. We've taken the Hippocratic oath to do so. And we're, federally required to do so. And so, I can speak, also in generalities about what we're seeing is that ER volumes are down, 50%, 30 to 60%, depending on where you work. And so, that's led to, and this is, there are national articles talking about this, that, ER physicians and nurses and staff are getting furloughed and their hours reduced and all this stuff because people are not coming to the emergency department, probably, to help us flatten the curve, obviously, which is what we want, and we're encouraging to help us in that regard. But if you're really sick and have an emergent condition, we don't want you to stay home. We want you, we want you happy and healthy and living. And, we're to that end, we're still here and happy to help you.
Yeah. I think it was interesting. The numbers in New York jumped by 4,000 today because EMS was getting killed. And what they were finding, and they figured out that, the numbers of deaths had gone up by 4,000+, and those were people they think that died at home either because of COVID directly, or they had these other problems and didn't want to go anywhere, and they ended up dying at home. And so those numbers have skyrocketed in New York, and they're adjusting their COVID-based numbers based on those because suddenly they had a jump of 4,000 deaths at home from the previous months and this time last year. And so those are things that we need to be aware of. We were joking when we were working the other night, about whether patients could get COVID from other patients. And we said, well, as long as they refrain from going around and licking the other patients, you should be fine. So if you take reasonable precautions and putting people in masks, we're sterilizing the rooms. I agree that the emergency department is not a sentence to develop COVID, as long as everybody's taking precautions just when you walk in the door.
Right.
Mask and. So it's a safe place to go.
Right, because the screenings, if you can, are being done outside, where the risk of transmission is much lower because you're not indoors, and it's generally, especially now it's to get a little warmer, which makes it even harder to transmit this. So, you can, I think have faith that your local emergency department has done everything possible to be well prepared for this, and this is across I know ER doctors, the emergency medicine community is small. There's only probably 1,000 of us in North Carolina total. so the community is really small, and we talk amongst each other all the time. And I think it's reasonable to say not just in the areas we are, but all over North Carolina, people are really taking this very seriously in the emergency departments and have done, I'm sure, gone above and beyond to be planned and prepared for this.
Yeah, I think that communication amongst the emergency medicine is a pretty small family, and I would say like this has really been a disease that's focused on emergency medicine and critical care, which is another pretty small.
Well, and infectious disease, I think we got to throw them a shout out there too.
Yeah, we'll throw out a little bit of a bone to the ID guys too, and ladies. But anyway, one of the things I think we've both been sort of impressed with is how quickly we've adapted to this disease. Mm-hmm. And I get questioned all the time, and I think just today, like 3 or 4 people have asked me about, posted that links to that video of the critical care guy in New York who said this is an ARDS, this is something else. And I think we would probably agree with that our management of these critically ill patients has gone from, oh my gosh, intubate them, put them on a ventilator immediately, to like really going, oh, let's hold off. And I had that patient the other night who came in with an oxygen saturation in the field of 50%, and we were all dialed up and had everything on and ready to go. And he gets wheeled in, and he's sitting there looking around going, what's going on here? He was sitting at 80%, but he looked great. So we ended up not intubating him, whereas before we would have intubated him no matter how he looked based on his oxygen saturation. Mm-hmm. And so that's radically changed. And, I think I get lots of questions about hydroxychloroquine and azithromycin and remdesivir and, BCG immunizations and all these other things. And I think that the problem is that this stuff is coming at us like a fire hose, and we've got to be able to evaluate whether it's legit or not. And that's where we're kind of struggling right now.
Yeah, I think that's something we kind of should have mentioned, obviously, in reopening the economy is we need, quite frankly, Jeff, we don't have a drug that we know works right now. The studies on hydroxychloroquine and Plaquenil, the initial studies, and if you're interested in all this talk, I post updates on my personal Facebook page, much like, Dr. Galvin does the videos. And so, I've done some pretty, intense paper reviews on, these studies. And so you can go back and look through my Facebook page and read all the stuff if you want to. But on the Plaquenil and Zithromax, if you excluded the people that died, yeah, it worked. It worked to the rate that people would get better without any medicine. And so that's been there. And the antibody testing, was kind of mixed, at least out of China, but they did it on a super, super sick population of people. And then if you look at Remdisivir, you're like, okay, maybe, the well people still, the less sick people still got well, but how many of those would have gotten well without it? That's the question there. And of the critically ill people, half of them, people got extubated, but a lot of them are still on some are still on BiPAP, some are still admitted. And so the goal here, the endpoint, I think that we're all looking to measure survival. It doesn't matter really if they're, the amount of oxygen they needed when they were on a breathing machine is 100% or 70. Yeah, that's improvement, but it's not clinical. It's numerical improvement. It's not clinical. Like, people want you to have what I'm looking for is, are people getting extubated at higher rates? Are they getting discharged from the hospital at higher rates? Are they surviving at much higher rates? And so, to that end, I haven't seen, anything really that's out there. So I think the one thing I've anecdotally have seen people that it's getting and seems that is helping is the tocilizumab. Actemra, that seems, anecdotally seems to be a medicine that's helping these really, really sick people to get better. But that's, I haven't seen any, honestly, I haven't seen any literature on it. I've just seen it out there, and it seems to be that, to me, and kind of following progress of patient stuff really seems to be making a difference. And, like you said, the strategy around this, how we're doing, is just completely changed. We would, like you said, be intubating early. Now it's permissive hypoxia, because now there's some data out there about the affecting the beta 1 subunit of hemoglobin, and so you have 4 subunits and one of them's basically inactive, but you can still breathe on that, okay, and it's assuming you don't have COPD or cystic fibrosis or some other, debilitating underlying lung illness. And we used to think it was, an acute respiratory distress syndrome type of process, or ARDS, that does this. And then we look at some autopsies and well, you've got lots of microthrombi and microhemorrhages in the periphery of the lung. So now you're talking about, is it antithrombotics, heparin stuff that's the answer, and we're definitely keeping these people, even if they're kind of looking like they're septic, we're trying to, normally we would give you tons of fluid, give you liters of fluid and all that stuff. And these people were tending to see they're doing better if they're a little dry. So as long as their volume status clinically, looks like they're pretty well hydrated, then, we may even keep you a slight bit on the mildly dehydrated side, give you like a dose of Lasix or something, every other day or so, just to make sure that we're keeping a little bit of a net negative fluid balance. So there's a lot of things out there that, in the traditional sense of sepsis or how we were treating this earlier, are a lot, different than what we're doing in reality now. And it's a constantly, evolving thing that, obviously we're having to, all the ER physicians, and we're having to read. I mean, not that we don't ever read, we have to do certain amounts of CME every year, but I mean, I'm doing yearly amounts of CME in 2 to 4 weeks now.
Yeah, I know. It's true. It's changing, rapidly. The interesting thing is that, what we've talked about in, just one-on-one, that, you need to have these randomly controlled trials. What does that mean? You give one group the medicine, you give the other group, you don't give it to them, you give them a placebo, and then see what happens. And, those things usually take, a year or more to get approved and everything else. Well, the approval process is in hyperspeed. And I think there's 2 giant randomly controlled trials that are starting in New York, this week, that are giving hydroxychloroquine and looking at developing the virus. So they're giving people it prophylactically, and another group isn't getting it. They're going to look at see if it's potentially preventive, because if we had something that could prevent you from getting it, then that would be a game changer. But we don't have anything that shows that. And then, there was a study that came out of China, just released last day or two, not peer-reviewed, preliminary, but they had 150 patients that got hydroxychloroquine that were in ICU level care. They did not see any drop in viral load whatsoever. And the one group that got it maybe had a little bit less symptoms, but there was not really any outcome. They all ended up surviving. The people that got the hydroxychloroquine had maybe slightly milder symptoms. So we've seen, nobody's been able to reproduce that initial French study that was so terrible. That's been several people, groups have tried to reproduce that guy's results and haven't been able to do it. So I think the jury's out on a lot of these medicines. We're using them though. I mean, we certainly, they're on the protocols, we're using them.
Right. I mean, if you're going into a fight with someone that has a bazooka and all you have is a pocket knife, you're still going to use your pocket knife. I mean, we're going to do anything that, and I think that the other thing to consider with these medicines is they're both pretty safe. I mean, there's some, you obviously have to do continuous cardiac monitoring, you have some QT prolongation and stuff like that. But I mean, on the whole, I mean, Plaquenil and hydroxychloroquine are both, safe medicine. So as long as you're doing the requisite monitoring for it, it's likely on those things where it's probably not going to harm you and it may help you. So I mean, by all means, we're going to give you the medicine that may help you. So we're going to do everything we can for you. It's just that, you're still looking for that, that magic bullet. And, kind of to the point you were sort of raising a minute ago, I think part of the thing we've got to ask is, are we asking the wrong question? Should we be, to some extent, if you go to your doctor and you have a cough, and you're coughing up green stuff and have a fever, oh, you probably have pneumonia, here's some doxycycline or Z-Pak or Omnicef or whatever, hope you feel better. Well, they don't wait for you to get intubated to give you the antibiotics. Right. So the question, but it's hard to ask that question now. I think the other question you've got to ask is, this is going to require a whole shift. Obviously, we're trying to focus on saving these people's lives who are really, really sick. And that's obviously where our focus should be right now, because it's kind of where it has to be, because there's just not the resources for it to be other places. But I think there's reasonable questions to ask is, and that's, again, this is going to take randomized controlled trials to figure this out, and a very long time is, whenever you test positive, is there something we can put you on then that keeps you from progressing? And I mean, it's just going to take a long time to figure this out. I think one of the big things about this, even though this virus has been out since November, man, there's just so much we don't know.
So much. You're right. We don't know. I mean, we've got a thimble full of knowledge, and we're trying to scoop, out the pool, and that thimble is getting bigger and bigger. But again, and I told people, I think earlier in the week, I said, listen, what I may be saying today, I might come back a week from now and say, hey, we were completely wrong.
Right.
We thought it was green, it's actually blue.
Right.
we just don't know. And I do think that it's a credit to the people who are on the front lines, how quickly we've been able to adapt and improve outcomes by kind of sharing information. And, this isn't like some mad scientists secretly in a lab working all by themselves. It's become a very collaborative process. Just the number of studies that are coming out with no peer review, we would never even look at a study like that. But now, we're looking at these studies because it's all we've got. And, and you can start there is some power in a bunch of non-peer reviewed studies if they're all looking at the same thing and coming up with similar results.
Right.
And maybe in those cases we can say, hey, there's 10 studies that sort of show this. We haven't gone through the whole process, but there's a trend here. We should this may be legitimate. We might want to start going down this path until we learn otherwise.
Right.
So anyway, I think that we'll probably, stop here. Folks, if you found this was helpful, having John here, I thought it was incredibly helpful. John definitely takes a much more academic bent. And if you read through, go to his Facebook page, he has these a lot of it's localized because we have localized data here, but great data about testing, does great literature reviews about different drugs and things like that. I look at it every day. I recommend that you do the same thing. If you think this is helpful, John, you willing to come back?
Yeah, man, I'll come back. I'm off of the night shift train after a month in a row. So I'm excited about that. My wife is excited about that. So so I'm back on day shift train for a while. So yeah, I can join you pretty much any time for the next few weeks.
Cool. Yeah, you have nothing going on in your life, right? I mean, it's not like
no, nothing at all. No 33-week pregnant wife. No. Leadership responsibilities for an ER, no 160-hour clinical work months, none of that stuff.
Nothing like that. Excellent. John, thanks a lot for coming. Appreciate it. And we will, for my normal viewers, we'll be back tomorrow with an update. As I always say, wash your hands, take care of yourselves, take care of your families, and take care of everybody else. We'll talk to you tomorrow.